Alright, so like we were saying earlier, acetylcholine nicotinic receptors are really important in muscle contraction. And so you're going to see some of the direct acting muscle relaxants like Botox working on either stopping the release of acetylcholine or some of these other ones that can be depolarizing or non-depolarizing, working on the nicotinic receptors themselves. But then we also have central acting relaxants, which we'll talk more about in a little bit. But for these skeletal muscle relaxants, they're used in pre-ops when you don't want somebody's muscles contracting while you're cutting on them, or they can be used in spastic diseases like MS and cerebral palsy. So basically, you have the spinal cord with your nerve fiber releasing acetylcholine at your skeletal muscle. Peripherally acting muscle relaxants, Botox is going to be one. It's an acetylcholine release inhibitor. Again, this is used for a couple different things, mostly cosmetic. On your non-depolarizing muscle relaxers, pancuronium bromide is a pretty common non-depolarizing nicotinic receptor blocker. You don't see names for general use because these types of muscle relaxants aren't for general use. So you're not going to be able to get any of this pancuronium from your pharmacist, right? These are hardcore muscle relaxers. Succinylcholine chloride is another one. This one is a depolarizing nicotinic receptor blocker. And so what it does is it causes an initial depolarization of that nicotinic receptor, but then inactivates it. And so it can't keep doing its job. Where the non-depolarizers kind of just stop it, right? They just kind of like plug the hole. This one will depolarize and then inactivate that receptor. Another thing is succinylcholine can release histamine from mast cells. And so with this, you can get the production of bronchospasms because it's basically acting like, giving you like an allergic reaction or an asthmatic reaction. Botulinum toxin is the thing that causes botulism or food poisoning. And occasionally, you can get too much of this toxin. I mean, naturally, if you get botulinum, or if you get botulism, like, the worry about it is it makes this toxin, right? And this toxin paralyzes muscles. And so the big worry about getting botulinum is it's going to paralyze your respiratory muscles, right? It can give you respiratory paralysis, and then you suffocate to death because it paralyzes the diaphragm. Occasionally, that can happen with Botox. Very, very rarely, right? It's more of a natural thing and not so much of a medical concern. Again, like I talked about with botulinum, you can get respiratory paralysis, but you can also get it with other muscle relaxants, especially your non-depolarizing. So if you look up here, we have a list of your non-depolarizing. There's 4 of them here. Any of those potentially could cause respiratory paralysis, right? But if they're non-depolarizing, you can use neostigmine to get rid of it. And we talked about that in an earlier lecture, how it blocks acetylcholine esterase, and so that means those acetylcholines are out there more. With your non-depolarizing blockers, it just means they're on that nicotinic receptor, and then they'll go away. And then if you have more acetylcholine there than you do the blockers, then you can get your contraction, and you don't have to worry about the respiratory paralysis. another thing, you can't, if you have the depolarizing blocker, if you have the succinylcholine, like, that one causes the depolarization and then the deactivation of that. So even when it's gone, like, that nicotinic receptor is deactivated for a while. And so you can't reverse it with neostigmine. Instead, you just have to put them on a ventilator and wait for the drugs to go away. Succinylcholine can also, in rare cases, one in about 20,000 cases, when combined with an inhaled anesthetic, can cause malignant hyperthermia. So typically this would be somebody coming in for surgery. You don't want their muscles to twitch, spasm, contract while you're doing the surgery. They're going to be under anesthesia, so you're putting them under, and then the next thing you know, their body temperature is through the roof. And it causes acidosis and a lot of other stuff, and it is typically fatal. Like, you have to jump on it really quick, start packing them with ice, and getting drugs to reverse that hyperthermia. Probably genetic, getting a good family history before you go in for a surgery is going to be key to keeping this hyperthermia from happening. Okay. Direct acting relaxant, dantrolene. This one actually works inside the muscle cell. So the other ones we've been talking about have been working on the outside, right? Stopping the receptors, stopping the signal, getting to the muscle. With dantrolene, it actually works on the sarcoplasmic reticulum inside the muscle cell, and it stops it from releasing calcium. If you remember back with muscle physiology, like, part of that whole muscle contraction loop thing is calcium has to bind troponin to move tropomyosin out of the way, right? Well, this stops that calcium from being released, so it can't bind, and so you can't get that contraction. It can be used to treat malignant hyperthermia. So if somebody starts getting it, you give them another muscle relaxant, which just sounds bizarre to treat a muscle relaxant with another muscle relaxant, but it's possible. And also a lot of your spastic conditions from, like, MS can be treated with dantrolene. Side effects: dizziness, vomiting, fatigue. It's hepatotoxic, so anybody that has liver issues should probably not get this drug, especially for, like, hepatitis or cirrhosis. The effects of it, with all of your skeletal muscle relaxants, you're going to see potentiation or an increase in the effects of these relaxants if you have alcohol or lidocaine. Certain antibiotics like clindamycin and streptomycin can increase the effects of these drugs. All right, and then we have some central acting relaxants. These are sometimes called spasmolytics, so they stop spasms. And what they do is they help to depress that reflex impulse in the spinal cord. And so it's used to treat muscle spasms, either due to trauma, overexertion, nervous tension. Sometimes when people, like, use their muscle too much, it causes it to become agitated, which causes it to send signals, which then causes it to contract, and you kind of get this positive feedback mechanism going on, where the damage is causing it to contract, which is causing more damage, which is causing it to contract. And so you need these spasmolytics to just kind of, like, okay, stop that from happening, right? And so to treat stuff like MS, you can use tizanidine. It's a GABA agonist. GABA is a major neurotransmitter in the central nervous system that is inhibitory, and so it stops a lot of signals. And so you have this drug acting like GABA, sending inhibitory signals, which means it just makes it a lot harder to get a signal through, to get a contraction. It's more difficult. And with these spasms, like, they're really quick things. And so with the GABA agonist, it makes it a lot harder for those little quick things to go off, typically stopping them. Some other ones, like Valium, is also an or a spasmolytic. But typically, Valium and some of your cyclobenzaprines are used more for anti-anxiety or as tranquilizers, and less as spasmolytics. And so here you can kind of see how your different muscle relaxers are working. Your benzos working here, and then that is it for our muscle relaxers. I'm not going to make you know any of these, just know that the central acting muscle relaxers work on GABA receptors.